Our next presenter happens to be the co-chair of the meeting, Tim Blackwell. To introduce Tim a little more fully, he is the Ralph and Lulu Owen Professor of Medicine, Professor of Cell and Developmental Biology, Professor of Cancer Biology, and Director of the Division of Allergy, Pulmonary, and Critical Care. We should probably just call him Professor at this point since he has 3 different ones.
Thank you, Greg. All right, I want to say first, it's been a real pleasure to host you all in Nashville for the last few days, and thank you all for coming. It's been a wonderful meeting, and the PFF, and particularly Greg, has done just an outstanding job to make this happen. So I am excited to tell you about some of our work this morning that has to do with the natural history of interstitial lung disease, and in particularly we're going to talk about an at-risk cohort study that I hope will be a nice follow-on to the information that you just heard from Matt. So here are a couple of disclosures for me, and then I want to move on to talk about natural history. Now, you've heard at this talk, or at this symposium already, a number of talks that implicate the natural history of IPF post-symptom onset or post-diagnosis. Many studies have shown for the last 20 years or so that there's a 3 to 5 year median survival after onset of symptoms, and that's quite variable, as has been noted on several occasions. But what's not clear really is what happens prior to symptom onset and prior to diagnosis. We know from other lung diseases that there can be a long pre-symptomatic period. We see this in pulmonary arterial hypertension, where up to 80% of the small vessels may be obstructed, occluded, or lost prior to diagnosis. And COPD, another chronic lung disease, is characterized by loss of small airways and emphysema that occurs long before symptoms. So it's reasonable to think that this could occur in interstitial lung disease as well. We also think that identification and acquisition of disease early could lead to more effective treatments, and as you've heard also prior in this meeting, it could be that earlier treatment could lead to real impact on disease course in ways that we don't see with treatment of relatively late-stage symptomatic disease. Also, one of the main drivers to get us interested in this area was the idea that once you have extensive pathology, a lot of the pathways and a lot of the abnormalities that you identify may be related to the response to the disease as opposed to the things that initiated the disease in the first place. And so what we really wanted to get at is identifiers of primary pathology and pathways that might link the genetics to the real etiology of this disease. And despite some really amazing data that Matt and others have shown, this is really hard to study in the general population where you have a prevalence of disease in maybe something like 1 in 10,000. So that makes it hard to identify this in an unselected group. So we chose to do this in our familial interstitial pneumonia families, and just to define this again, you've heard some of this already, but we think that around 20% of IPF is familial, and this is defined by having more than one case that is in a family that has bloodline relationship. When you have disease and that runs in a family, it seems to be pretty similar to the, quote, sporadic cases. The radiographic and pathologic features are similar, and the course is reasonably similar. Most families, and the ones that we've identified the genetics for up to this point, suggest an autosomal dominant inheritance pattern with incomplete penetrance. And you heard a lot of talk yesterday about telomerase pathway mutants, as well as some discussion of surfactant protein pathway mutants that identify the bulk of the disease that we can assign to a specific gene to date. So a long time ago, it occurred to us that siblings and children of patients in these families may have increased risk for disease, and that this might be a group that would be worthwhile to study. In fact, we didn't think of this. This idea has been around for a long time. In fact, a really nice paper from Peter Bitterman when he was working in Ron Crystal's group back in the 1980s was the first group to show that you could identify abnormalities in asymptomatic relatives of ILD patients. And what they found were some inflammatory changes in a subgroup of at-risk, if you will, family members. In addition to that, we had worked with David Swartz and Mark Steele, who had a really fascinating paper published in 2005, which you've also seen reference to, where they studied over 100 families and found that 1 in 8 of these at-risk people had radiographic abnormalities. And so that study was published in 2005. We thought about that for a while, and in 2009 launched a study that we we describe as the early IPF study. And the idea of this is to identify siblings or children of FIP patients, so first degree relatives. We enroll patients at age 40 to 70, and interestingly, since that time, have expanded this in some families where there's relatively young onset, so that if you're 5 years younger than the youngest person in your family, then you're eligible to be enrolled. Our only exclusions really were people who had other chronic lung diseases. So if you had another a known ILD diagnosis of some type or other chronic lung disease that caused symptoms, we excluded you. And we also didn't want to have people with substantial dyspnea, so we used this dyspnea score and try to get people who were not getting short of breath when they were walking down the street. The idea when we started was to develop risk prediction models for the development of IPF, figure out what the radiographic and other kinds of measurements that we could make could predict disease onset. We wanted to figure out the best way to do early diagnosis, and ultimately, because this is tied to a genetic study, we wanted to make a correlation between the genotypes and the phenotypes and figure out whether we could make even more precise idea of disease progression and early onset based on what gene runs in your family. When we started, we had an initial protocol, which is listed here, where you got a high-resolution CT scan. We drew blood, and the first 100 patients who agreed, we also did a bronchoscopy with BAL and transbronchial biopsies. Actually, we did transbronchial biopsies on about the first 75, and then the last 20 or so, we did cryobiopsies with Fabian and Otis Rickman, another interventional pulmonologist at our place, and have some really interesting data from those. We have had an annual survey from the beginning that we have added to over the years, and our current protocol listed on the other side is that we now have an electronic questionnaire that goes out by email to patients, and they go on our database and fill that out. And then we've started 5-year follow-up visits where we do high-resolution CT scan and blood draws, and we're just starting to do pulmonary function testing. So the characteristics of the participants now are that we have a total of 284 patients that have completed enrollment, meaning that they've signed the consent form, they've donated blood, and they've had a high-resolution CT scan. The age at enrollment is 52.3 years old, and the current age of the cohort is 56, showing some of the longitudinal piece of this. Now, it's really important for you to note at the onset that the average age of clinical disease in these families is 65 years. So these are about 13 years earlier than the average onset of clinical disease. Most of these patients are female, and that's because females are most likely to sign up for studies, and 26.7% are smokers, which is about the prevalence of smoking in the Middle Tennessee region. To date, we have enrolled patients from 135 families. Many of them have 1 or 2, but we have a few families that have been really interested in this study, and in 9 of them, we have more than 5 participants in an individual family. We're also trying to understand the mutations that go along with these families, and in 3 of the families, we have surfactant protein mutations, and 18 have telomerase variants. The rest we're still working on. So what we found is that abnormal high-resolution CT scanning is common in this group. In fact, it increases with increasing age, and you can see a couple of examples of these reticular-type infiltrates that show up basally and peripherally. I'll show you a little bit more about that in a second. Overall, of these 284 subjects, 23% of them have abnormal high-resolution CT scans, and interestingly, it's very different whether you smoke or not. So you can see in this graph that this onset of these abnormalities is related to age and smoking. And I'll just point your attention to the dotted line there with the smokers, where if you're 65 and you're a smoker, then you have about a 75% chance of having an abnormality on your CT scan that our radiologist thinks could be related to early interstitial changes. And so these are reticular changes that are consistent with development of fibrosis. In the general population, you've heard that somewhere between 5 and 8% of people this age may have this abnormality. So this is an order of magnitude above that. I should also point out that if our genetic assumptions are correct, only 50% of these people have genetic risk. So clearly there's some people in this group that are not likely to develop disease that have these interstitial changes. So trying to understand those connections is critically important. The other thing that I'll say is even if you're a non-smoker and you're 65 and you're in these families, you have a 50% chance of an abnormal HRCT scan. So again, suggesting that being in a family, having the right genetic makeup makes you susceptible to these, and then the question is how frequently will these progress to symptomatic disease? Now, the way our radiologists have read them is that they take these HRCTs and they reconstruct them and they divide them into quadrants. And I want to show this just to point out that the areas that we think of as harboring the changes of early disease may be right and may not always be right. So in general, the right base, where you can see there's 33% of the abnormalities occur, is where we typically find changes. But 25% of these in the right side happen in the middle and upper lung zones, and the similar distribution is true on the left side. It's just that there are fewer abnormalities detected there. So we don't understand the meaning of this, but clearly there are changes outside of these basal subpleural areas that may have relevance in this disease. So what do biopsies show? Well, this is some information that John Kropsky published in 2015 for the first 71 before we switched over to doing cryobiopsies. And what you can see here is that 26 of those, or 36%, were abnormal. Now, we don't know what early fibrosis looks like. We can see fibrosis, but it could be that other things like granulomas and airway-centered inflammation may also be predisposing. So we didn't have our pathologist define this in any specific terms, but these are just the abnormalities that they saw. So it's interesting because a lot of these people are abnormal. Many of them had completely normal high-resolution CT scans, and I must say that there was almost no correlation between an abnormal CT and an abnormal biopsy. So these are subradiographic type lesions primarily, and the implications of that, I think, are still something that we're struggling with. We did a number of other things to characterize this group, including looking at telomeres, because we've been very interested in telomere shortening. And what you can see on this telomere plot here on the left-hand side is that these are peripheral blood telomeres, and this is normed for age. And so I've circled the group that's below 10 percentile for age, and obviously that'd be 10% of people in the normal distribution. It's 36% of these folks, and you can see how skewed on the low end the peripheral blood telomere links are. So suggesting to us that short telomeres could happen early in predisposed disease as opposed to something that occurs as a result of the disease. Now that idea is actually further supported by the other type 2 cells that are shown here in this picture, with the CO standing for pro-SBC and the FISH for telomere. And so we quantified telomere length in type 2 cells on biopsies from normal patients and IPF patients. And just like Mary showed you yesterday, in IPF patients, their type 2 alveolar epithelial cell telomere length is quite short. And in fact, there's no overlap with the normal controls. But I'll point out in the middle group, the at-risk folks, where we have 70 samples, many of those are really short and in the range of the IPF patients. So again, suggesting that these cells that are in sometimes regions where the pathologists believe that the lung is completely normal have very short telomeres, and suggest that that might be a driver of disease as opposed to a responder to disease. We've been interested in the role of herpes viruses for many years, including EBV and CMV, and we've shown that these viruses are present in low-level replication in the type 2 cells in the distal lung in the areas of fibrosis. And so what we did in this study is we looked at this based on presence of viral DNA in the cell-free BAL. So presumably these are from cells that are lysed after replicating the DNA, after replicating the viral DNA, and we detect that with a quantitative PCR approach. So you can see that most of the, most of the IPF patients have a lot of EBV and CMV in their BAL. The normals have this as an uncommon finding, and the at-risks are in the middle, again suggesting that herpes virus reactivation might be involved in at least some of these individuals. We did some biomarkers with Eric White's group, and we found that of a panel of 30 that these 4, MMP7, SPD, endothelin-1, and TIMP2, were altered in our at-risk group in total compared to a age-matched control group, suggesting that some of these markers, which we see as being abnormal in symptomatic ILD, are also abnormal in these at-risk asymptomatic folks. And so when we looked at comparisons and predictors of high-resolution CT scan changes in the first 100 patients, what we found, not surprisingly, was that age and smoking correlated with these abnormalities. But interestingly, and maybe the best predictor was telomere length in the alveolar epithelial cells, again suggesting this may be a direct contributor to disease pathogenesis. The peripheral blood telomere length, in contrast, did not correlate at all with HRCT abnormalities. We also showed that MMP7 and SPD, 2 of the best validated markers for symptomatic disease, were also increased in the at-risk cohort. And then we've heard a lot about MUC5B here. Interestingly, in our group, the MUC5B status of these at-risk patients is intermediate between healthy controls. So you can see the risk T allele, the minor allele here, has a allele frequency of about 11% in the healthy control or general population. It's around 35% in our IPF patients, which is very similar to the dozen or so other studies that are out there. But there's an increase compared to healthy controls in the at-risk group with a normal CT, and that's even higher in the abnormal CT. Again, suggesting that there's some interaction here with the MUC5B status that is at least important in the early changes. So because we've been doing this study for 7 years or so, we're starting to get some longitudinal follow-up data that's interesting. We have an incredible population of people who are involved in this study. In fact, in this last year, we had a 70% response to our annual survey. We've done 57 follow-up high-resolution CT scans to date, and so far, out of the whole 284 cohort, we have 18 that have been diagnosed with clinical ILD. 5 of those had extensive disease on their initial scan despite having a normal symptom score, and then 13 have developed extensive disease or a new self-reported diagnosis during their follow-up time. This is what the radiographic progression looks like. You can see an example on the bottom that shows a dramatic progression. This is a patient from a family that's got a surfactant protein variant, and you can see between the 6 years, this person has had a marked change on their CT scan. Now, just like with everything else we've talked about, smoking is a predictor. If you smoke, your chances of having progression seem to be much higher. The progressors in our group have these reticular changes in septal thickening, again, mostly in the base, but not always. And so far, of the 57 patients that we've studied, 11 have radiographic changes. The table shows that some of these, and those are the groups that go from normal to early ILD or abnormal to progression. So the second and the bottom column there. So it's most of the normals stay normal, which is not too surprising. Some of the normals, really only a few of them so far, the 3 that you see, have developed early ILD. There also are a few abnormal scans initially that have normalized, 2 of those, and 2 that have stayed about the same over the 5 years. But it looks like, again with small data, that if you have an abnormal scan to begin with, your chances of progression are higher. Again, not surprising, but consistent with the idea that we really are finding things that are going to be important in implicating disease progression. And then this is just our composite data for abnormal CT scans and clinical diagnosis. So the black line that shows abnormal CT scans, again, as I suggested before, if you take all comers, you have a greater than 50% probability of having an abnormal scan in this at-risk group at age 65. And then this is the probability of clinical disease shown in the red line. What I want to show is the difference between those 2 lines. So the difference between those 2 lines is about 8 years. And so we think that might be giving us the first indication of what the lead time is between when the CT scan's abnormal and when we might expect to see clinical diagnosis. That, of course, is an important aspect of this study that we're going to need more data to really understand. So just to summarize, abnormal high-resolution CT scanning is something that we can detect in greater than 80% of our at-risk subjects. It's increased if you're older and if you smoke. There's a limited correlation between the radiographic and pathologic abnormalities, again, not making it unclear which of these, if either, is going to best predict who develops symptomatic disease ultimately. There's something about the short telomeres that shows up as being important. Many of them are short in the lung, and some of them are short in the peripheral blood. How those relate to risk is a critical feature of what we're doing going forward. And then we're also continuing to look at plasma biomarkers, herpesvirus, and this MUC5B SNP to try and understand how we could put together a risk profile that would help us to define progression. So just to summarize, asymptomatic individuals in IPF families have derangements in multiple pathways several years prior to typical onset of disease, and we hope that continuing to follow up this cohort will enable risk stratification, predictive modeling, and new mechanistic insights to help us really understand how to identify and treat this disease. With that, I want to thank a lot of people. John Kropsky has taken over running this study for the last several years and is just a fabulous junior investigator that you've heard from already. Lisa Young and Jim Lloyd are important folks in our group to really make these studies possible. We have a variety of former fellows that have contributed to this work, including Peter Krosno and Donnie Zoes, both of whom are here. And then most importantly are the patients, the family members, and our coordinators. So I want to start with the coordinators. We have had an incredible group of study coordinators who have really made this possible. If any of you are interested in finding out more about this study or putting your relatives in touch with our group, they're at a booth right outside that's got Vanderbilt University on it, so they'd be happy to talk to you. But they really are amazing in getting this work done. And finally, I am just blown away by the response of these patients and their family members to be involved in this study. We have people from over 30 states that have come to Nashville to participate, and they have been incredibly gracious to give their time and their samples and to really be involved in a continuing way to help us to understand the basics of this disease in a way that can lead to a different paradigm of understanding and treating it. And so I want to say thank you to all those folks, and thank you for your attention.